Aqua is the Advancing Quality Alliance, and we're based in Manchester, and we've been established now for about 3 or 4 years, and we are primarily a membership organisation composed of the vast majority of Northwest CCGs and providers, and we provide a range of quality improvement and patient safety functions for our member organisations. But apart from that, we deliver a number of national programs, and in 2012-13 we won part of the Department of Health contract around implementing shared decision making, and we ran a collaborative across 3 clinical areas, which were maternity, MSK and renal, to a total of 33 different teams, and we were testing out and developing an implementation plan for shared decision making across these teams. And Brooke will go into a little bit more detail later about some of the outcomes, but we have produced a range of resources which are available on our website, and also a Train the Trainer pack which is freely downloadable, again from the Aqua website. We have just completed our second collaborative, that completed in March of this year, and one of the things we noticed during our first collaborative that there were many similarities between the skill set for clinicians and provider organisations in delivering shared decision making as well as self-management support, which fits into what was being said about the house of care model. And so our last collaborative was looking at implementing at the same time both shared decision making and self-management support. And we worked with 28 different teams from both primary care, community care and specialist services across the Northwest. And we are just about to publish our report about that. That should be available on our website hopefully in the next few weeks. And we are currently delivering a 2-year program around transition services. So it's long been recognised that in children with long-term conditions, there is often a real harm that comes out of the transition from paediatric into adult care. So we won part of the Health Foundation's Closing the Gap bid, and we are looking at implementing a model of shared decision making and self-management support into both paediatric and adult services, so we can better develop a seamless service for these children with long-term conditions. So if I could have the next slide now. So let's think about what shared decision making is all about. When patients face many different types of decisions in their journey through medicine, and one of the decisions they face, which probably arises about 50 or 60% of the time, so it is probably the commonest decision patients face, is what's termed a preference-sensitive decision. And this is where there is a range of possible valid options to the decision the patient faces. An example of this may be whether a patient with a gluea has a grommet fitted, whether you would prescribe antibiotics for a sore throat, managing mild hypertension. And so the one treatment option may be around lifestyle changes, around behaviour modification, and another treatment option may be the prescription of some medication or actually some sort of surgical intervention. So shared decision making is actually designed to better support the patient when they are at a preference-sensitive decision point, to make a decision that's right for them as an individual. Because what's vitally important is to actually look at the whole patient in a holistic manner and recognise that there may be factors in that patient's life which would be crucially important as to what decision is right for them. And also some of the skills in the clinician, if one of the options is around behaviour modification, smoking cessation, exercise, that to have the skill set as a clinician to support the patient make those choices is also very important. So what Aqua has been doing is developing and supporting clinicians and providers develop these skill sets and to develop and use the tools that support patients at this preference-sensitive decision point. So if you could just move on to the next slide. So this next slide shows one of the quotes that has come from our first collaborative. This was one of the renal consultants who was engaged in our first, and it actually highlights a common feeling that many patients have a very unintentional paternalistic model of healthcare. I think particularly for doctors, when we go through medical school, we're taught to, when we have a patient in front of us, to take a history, conduct an examination, maybe carry out some investigations. We then hopefully come to a diagnosis and prescribe a treatment. The patient's role in this is almost a passive giver of information, or they allow an examination or some investigation to be undertaken. I think when I went through medical school, is what we didn't realize is that patient preferences are equally as important, what their expectations, fears, what their social circumstances are, what their attitude to risk is. So I think it's very important we develop this holistic attitude. And when we get this right, I think there are huge benefits. I think speaking as a clinician, I think it makes your consultations much more focused, much more patient-focused, and actually more successful. You end up with clearer risk communication. Patients understand the pros and cons of treatments much better. And I think coming out of that, particularly when things do go wrong, there is now good evidence that there is reduced litigation and reduced complaints. Also, you better support patients to make those behavioural changes which are so vital in supporting long-term conditions, such as weight loss, exercise, smoking cessation. And there is some evidence from recent Cochrane collaboration reviews that this could be a more cost-effective way of delivering healthcare. I think there needs to be a slight health warning around some of the costs, because much of the data around cost and shared decision-making comes from North America as opposed to Europe, or more particularly the United Kingdom. And I think there is quite a different model of healthcare there. And I think what's most important is patients have an improved experience of the consultation and healthcare when they've undergone shared decision-making. They feel more empowered, more satisfied, and more in control of their decision-making. If I could have the next slide, please. When we don't get shared decision making, one of the downsides is we get unwarranted variation. And I think if you look at the Right Care Atlas of variation, it's sometimes quite shocking to see how extreme the unwarranted variation can be. This slide I've taken from the latest Atlas of Variation, and it shows the variation in DEXA scanning across England. DEXA scanning is something which is quite robustly covered under NICE guidance for osteoporosis. So there is a very clear right pathway for patients to be DEXA scanned, and yet there is a 50-fold variation across England in DEXA scanning rates. So this tells me that there is, in some areas, a lot of overscanning, in some areas there is underscanning, and it's a pathway which is not evidence-based and actually driven by patients making empowered, informed choices. So could I just move on to my last slide, please, before I hand over to Brooke? This also was a comment from a general practitioner involved in our collaborative, and I think it raises a couple of points for me. I'm not going to read it out, but I think we live in a very different time of delivering healthcare, and one of the aspects which I think is often lost is continuity of care. And what this general practitioner was saying, in times gone by, he knew each patient as an individual, and often that was true for consultants delivering long-term condition management. I think that is much rarer these days. So I think it highlights to me that we need to be honing our skills in shared decision making to make sure we don't disempower patients. When we've known patients for many years, we've known them, we know their families, we know what's happened to them in the past. So I think it's much easier to deliver personalised care. but I think now we need to be actually concentrating on shared decision making as well. I think what I'll do now, conscious of the time, I'll hand over to Brooke to talk in more detail around what Aqua's been doing.
I'm Brooke Howells. I'm Programme Manager with Aqua's Shared Decision Making Programme, and I also work as a facilitator on the programme, which means I support clinical teams across a range of conditions and from a range of different backgrounds, as Alan was saying, community, acute and primary care, as well as mental health services, to help them put shared decision making into practice. And it's very much something that, because it's a culture change, albeit quite a subtle one in some cases, it requires time to think about what your current practice is and how you can change that. And it's not something you can change overnight. What we found working with the teams we've supported over the last couple of years is there's a few key things you can be looking at to get it into practice, and that's what I'm going to focus on now. And those key things are about supporting patients to get involved. Very much this is, as we say, a two-way dynamic, and so some of the responsibility is on patients to be more involved as well, and we have tools and resources to support that. We help clinical teams to look at how they structure their conversations and make sure the options are discussed clearly. We look at how people can provide evidence-based and balanced information as they're going through the options. And we also do quite a lot about asking patients what they'd like more of. And I'll just say a bit more about that now, which is we encourage all the teams we work with to consult with patients, maybe having a focus group or using an email network forum to ask them what it is that they'd like and for their experiences of the service. And we're particularly keen, where teams are working on this as a project for a length of time, that they invite patients to sit with them on their project steering group and be part of the development of that. So it's very much a shared experience, not just in the one-to-one consultation, but as you're developing your services as well. If we could have the next slide, please. So in terms of supporting and encouraging patients to get involved, as I say, it is a two-way dynamic, and we're conscious that not all patients will necessarily be ready for a clinician to ask them what their opinion is on options and for them to be more involved. And we see this particularly with more elderly patients, but not necessarily always more elderly. It's a lot just to do with how people have experienced the NHS in the past. And so we've developed a resource, Ask 3 Questions, which is based on research done in Australia around 3 questions that can help people be more involved in their healthcare. And it's also based on some work that the Magic team did as well prior to Aqua's work. And it's a very simple tool that gets people thinking about what their options are and thinking about considering them and looking for support and how to make a decision, so they don't just take the clinician's first bit of advice, but they open up a conversation. And the resources we have for this, we have a number of different leaflets and posters. There is an animation that's available to download off our website, or we can send it on a USB stick if you struggle to download it, which is good for putting up in waiting rooms. And we see people using this both within waiting rooms and also putting it in appointment letters or sending it out prior to appointment to get people thinking about how they can be more involved in their consultation, and just being aware that there may be different options and it's something to consider. Next slide, please. So in terms of the work we do with clinicians, and our primary focus is on helping clinicians develop their services, we look at restructuring conversations, making sure that you get both the patient input and the professional's input equally into the conversation. And this is done through agenda setting, and I'll show you an example in a moment of an agenda setting tool, which essentially is about making sure the focus of the conversation is on the priority for the person that's come to see you that day. And negotiating if there are a number of different priorities. You may, as a clinician, have priorities as well, making sure that you focus on what's most important at that time. And then once you know what decision you're looking to make, what's the priority for the day, it's about information gathering from both sides. And as you can see here from the bullet points, there's an equal opportunity to be involved here. So as much as the professional has a lot to put into the conversation in terms of their knowledge about what the diagnosis is and the cause of the disease and what the different treatment options are and the outcomes from each of those options, the patient has an equal input into this in terms of how they experience the illness, what their social circumstances are, their attitude to risk, particularly in relation to this particular problem. We all have different attitudes to risk in different circumstances, and what their values and preferences are. It's maybe as simple as preferring to have a tablet rather than an injection, but it could be a much bigger preference, particularly when some of the decisions made in healthcare have a big impact, particularly in things like choice of dialysis. The patient's preferences and values and their social circumstances will have a big impact at that point. And then once you have that information, you can go into looking at the decision and going through the structure of that to see what was best for that individual at that time. Next slide, please. Okay, so this is just one example of an agenda setting tool that one of our teams developed to help patients think about why they'd come in for that appointment that day and what was important to them. This is a chronic pain team. We recognised that there might be any number of concerns people were coming to them with, and to help them focus on what was most important, because quite often the patients coming to see them couldn't necessarily be cured, and it was about self-management. It was about helping them look at the key things for them. And I particularly like this tool because you can see at the top right, they've included the impact on relationships and sex. Which you can imagine, people suffering with chronic pain, it could be quite a concern for them. And when the team developed this, it was actually some of the clinicians who were a bit iffy about putting that on the tool. And it made them realise that if they were struggling to have that conversation, there may well be patients who needed a bit of help to prompt that. So there's very simple tools like this that can help you focus on your priorities. Next slide, please. And then once you've gathered information and you're sort of looking at the actual decision-making process, we work with this model for shared decision-making, which was developed by Glyn Elwyn and his colleagues, which helps people move from their prior preferences. So if they've come in wanting a particular treatment, it might be that they have a preference for that because their neighbour had it, or their friend had it, or they've read about it. And it might not be the most informed preference. So it's about going through a conversation that helps them have a preference that is informed based on the evidence and the different outcomes of the options and what fits with their personal values. And that's very much broken down into three parts, which is choice talk, which is about explaining to somebody why there's a choice, why it might be that there are different options and it's not clear which of them will be best, and how their personal preferences will have an impact on the decision made. The option talk, which is about going through each of the options and looking at the pros and cons of each. And then the decision talk, which is about making sure that you're both in this two-way conversation comfortable with the decision made, making it clear that you can go back and review this decision at any time. It's not, if you make a decision now, you close doors on other options, and making sure that the decision does fit with the preferences of the person that you're working with. And the idea is that going through these stages, you'll get a good decision that will be based on the evidence and on people's preferences, and not an impulse decision that they might later regret because they've not thought it through. Next slide, please. And this is Aqua's way of presenting the choice option decision structure. We think it's a bit of fun for people, but we do find people find it sort of an easy way of remembering those three things. And we do actually have a supply of postcards if you'd like to have a little picture of a card in your office or in your notes that we can send out to you. And as I say, we find it a good little aid memoir. Next slide, please. And this is another quote from somebody we worked with in in the National Collaborative, talking about how that structure, for some decisions you might think you don't need to have such a defined structure, but it really helps some people to make sure that they've approached a consultation looking at all of the different aspects. making sure people are aware of why there's options and being prepared to be involved in that decision. And then, as this consultant said, it was a useful structure to put into the letter afterwards so that the patient and the clinician were both very clear about the discussion that was had and how they move forward from that. Next slide, please. So in terms of helping people look through the options, as a facilitator, I always say to teams, you don't need a decision aid to do shared decision making. It's very much about the way you have a conversation with people and making sure that they're aware of what the options are. But where decision aids do exist, they can be really useful tools to help you have this conversation. And there are two types of decision aid. The screenshot you can see at the moment is one of a long form decision aid, which is an interactive online tool. They take quite a while to go through, maybe 45 minutes to an hour, but they're quite detailed and they have the benefit that you can, because they're interactive, you can go through as a patient and put in your values and your preferences, and it helps you to compare different options against those preferences as you go through. You can print off the information at the end to take back into your next consultation, and there are also short videos of people who've made similar decisions and talking about their experiences and information about where to get support from people. The one thing teams sometimes say to us about these is that not all of the options available or advertised on these tools are available in their area. But I think the osteoarthritis of the hip is a great example, because complementary treatments might not be available in your area on the NHS, but it might be that that person's personal preference and values is that they'd rather have that but go private, and that's their option. And I think it's a great example of how having these discussions can open up different options and make it a very two-way process. Next slide, please. And so this is the other form of decision aid that's available, which is a short form aid known as an option grid. And these are short, usually only one side of A4, and they are very concise comparisons, usually of two options, occasionally of three. But you can see here that they have for each of several frequently asked questions about a particular condition. They compare the options side by side, so for each question you can look at how the two compare, and it gives you a very clear and concise way of comparing options, and these are really useful to use in a consultation or possibly as part of, it might be something that you give to a patient to take away with them after and to have a think about as they're having their conversations. Next slide, please. And again, just another quote there from one of the teams we've worked with, the physiotherapy team at Aintree. Much like a lot of the teams we've worked with, who recognised that they were already doing some shared decision making, but not as formally as they possibly could do, and they found it really useful to apply a structure and look at how they could make sure they were consistently putting shared decision making into practice. Next slide, please. And as part of that consistency and getting the quality, we really encourage teams to measure how well they're involving people's decisions. And there are two sides to this. Firstly, it's about looking at actually how well are you involving people with the decision, with that conversation. And we use two tools for this. The Collaborate tool, which is the first three questions you can see on the slide there, which is about, as you can see, getting people to think about how much effort was made to involve them in the conversation, and it doesn't necessarily matter if a particular decision was made. So we use this a lot with people looking at long-term conditions where you might be having a conversation about self-management, but there's no particular decision made. And then also the Sure tool, which is questions 4 to 7 on this slide, which is very much about a particular decision. It's a decisional conflict tool, and that also helps to help you as a team assess how well you're giving people support and the information they need to make a decision. And we support teams to look at these and use them as measures for improvement to assess where their service is at, and then make changes and see the impact of that as they go along. Next slide, please. And the other side to measurement is looking at what impact that involvement has. We call these our so what measures. Essentially, it's about helping teams to see that if they're involving patients more in decisions, and they can see from Collaborate and Sure that they are involving people more, what is the impact of that on their health and on the processes that go on in the service. So this is just a few examples of some of the indicators people have used. DNA rates is something, if you're involving people with decisions more, they quite often have a better experience and they're more likely to come to appointments because they value the conversation they're having. Length of stay, the graph there showing length of stay was for an intermediate care service who discovered that they were, the more they had conversations with people about options for discharge and whether people were going to go into long-term care or back home and what support they needed for that, meant that length of stay was greatly reduced because both the clinicians and the patients were working together to a goal that had been agreed, a shared goal, and that made the process much more smooth and efficient. And the graph on the right there is from a community equipment service, two different services within the same community area, who noticed that they got a lot fewer reported problems with equipment on handover because the decision about what equipment to use had been a shared decision, so people weren't getting equipment that didn't meet their needs and that they didn't actually want to use or that wasn't quite appropriate for them. So there's lots of different ways that you can use measures to look at the impact of shared decision making in your service, and we'd be happy to have conversations with teams about what might work best for them in that regard. Next slide, please. So then just a final quote from the maternity team at Blackpool, who were one of our strongest advocates in the national programme. They were quite sceptical to begin with, but they've realised that actually it's really helped them in the way they're working with people, and then they have a much more collaborative relationship with all the women that they work with now. And next slide, please. So the last thing I'll talk about is the resources we can provide. We offer training and advice from our facilitators who are experienced. We've worked with over 50 clinical teams now from a range of different areas, as I say, and we can offer training at a range of levels, from introductory workshops and overviews to half-day training sessions for particular teams, up to a train-the-trainer programme, which is normally aimed at a whole organisation to get a network of people trained up and skilled, ready to support the spread and sustainability of shared decision-making across the trust. We have on our website, you can see the link there, we've got a number of different resources, including a significant number of case studies from the collaboratives we've run, which are both staff and patient experience. And they highlight some of the challenges as well as the successes that we've seen, and a lot of the work that teams have been doing. And that's our contact details if anybody wants to get in touch for more information about any of that. And I think my final slide is just my thank you slide. So yes, so thank you very much.